Good afternoon, everyone. My name is Kristen Wan, and I'm with the Chronic Disease Prevention Team here at the Association of State and Territorial Health Officials. I would like to welcome you to today's interactive webinar, How State Health Agencies Can Support the Physical Activity Guidelines by Ensuring Accessibility Within the Built Environment. ASTHO, with support from the Office of Disease Prevention and Health Promotion, is working on this exciting project to assess the current uses of the Physical Activity Guidelines for Americans and to educate and mobilize state health leadership to utilize and integrate the guidelines throughout agency programming. ASTHO is working to capture state stories, develop an issue brief, and other resources to support the implementation of the guidelines, which will all be available on ASTHO's website. In addition, today's webinar is the third in a series of 4 webinars in the Physical Activity Guidelines for Americans webinar series, and a recording will be posted to our website in the next couple of days. The objectives for today's webinar are to provide an overview of the Physical Activity Guidelines for Americans Midcourse Report, describe the evidence-based recommendations from the Midcourse Report for the built environment, and to provide examples of how state health agencies can lead or support effective strategies to increase physical activity within the built environment. We have an esteemed panel of experts that will be speaking with you today. Following my introductions, all of the speakers will present their slides. If you have a question, you are welcome to post it in the chat box on your screen at any time during the webinar. These questions will be used during the Q&A after today's presentations. At the conclusion of the webinar, you will be directed to an evaluation survey. Please take a few moments to inform us about the work you are doing to increase physical activity in your state and to provide us with feedback on today's webinar. We look forward to hearing about your efforts. Our first speaker is Dr. Robin McKinnon. Dr. McKinnon is a health policy specialist at the National Cancer Institute, where she works on policy research related to diet, physical activity, and obesity. Her interests include the effects of food and physical activity environments on diet and physical activity, measurement of the food and physical activity environments, the economic and societal effects of rising obesity rates, and evaluation of public policies that may affect diet or activity. She also served as a member for the subcommittee for the Physical Activity Guidelines for Americans Midcourse Report. I will now turn it over to Dr. McKinnon.
Great. Thanks, Kristen, and good afternoon, everybody, or good morning, depending on where you are. Thanks for the introduction, and thanks for the invitation to present today. I'm going to be speaking about the built environment findings from the Physical Activity Guidelines for Americans Midcourse Report that was recently released a few months ago by the Department of Health and Human Services. And so the Midcourse Report is organized around 5 key areas where youth live, learn, and play: the school environment, preschool and child care, community, family and home, and primary care. And today, as mentioned, I'm focusing on the findings from the community section and specifically the built environment. And you can see on the slide the key message from this setting, the tagline, is 60 minutes or more a day where kids live, learn, and play. In preparing the report, the other members of the subcommittee and I reviewed the evidence on the intervention strategies to increase physical activity in youth. And we used a review of reviews approach to assess the current literature. And this is actually an important point because it has implications for our findings. So sometimes researchers will assess all of the studies that have been published on a particular topic, like, for instance, the impact of the built environment on youth physical activity, and then publish those findings in a review. And then we as a subcommittee, we reviewed those reviews. So we didn't look at individual studies. We looked at the reviews. So turning now, the community setting. The key message from the Midcourse Report here in the community setting is build the physical environments of cities, towns, and neighborhoods to encourage physical activity. And this is very important as changes to the community can shape social norms and the physical environment, and that in turn can impact all youth physical activity and not just those who participate in certain programs, and also has the happy benefit of potentially influencing adult physical activity as well. And of course, it's important that those changes accommodate those with disabilities. There were 3 subsettings within the community setting of the report. built environment camps and youth organizations and community-based programs. And I'm focusing on the built environment. But if you're interested in those other areas, please do check out the Physical Activity Guidelines Midcourse Report. What I mean by the built environment, it's worth spending just a minute here. By the built environment, we mean the physical form of communities, which includes things like the urban design, so how cities are designed, the physical appearance, and how it's arranged, the land use patterns, so how land is used for commercial, residential, and other activities, and also the transportation system, which are the facilities and services that link one location to the other. And you can see here the key findings that we found from reviewing the reviews in this area. We found that the evidence was suggestive of these aspects of the built environment influencing or increasing youth physical activity. We actually had 4 levels of evidence: sufficient, suggestive, emerging, and insufficient. And this area, the built environment, was suggestive. Most of the papers or the reviews that we looked at found associations between aspects of the built environment, these ones that are listed here, and increased physical activity, but most of them weren't conducted over time. But you can see here that very strong associations and very consistent also with what we see in the literature related to the built environment and adult physical activity. But the literature suggested that improving the land use mix so that there are a number of walkable, bikeable destinations, increasing residential commercial density, implementing traffic calming aspects of changes to the built environment, increasing parks and recreation facilities, and then all the other things that are listed here. And I do want to mention that this wasn't part of the built environment section in the report, but it's very much related. This was in the school setting of the Midcourse Report, active transportation to school. The evidence there was also suggestive that encouraging active transportation to school increased overall youth physical activity. And some people might be aware that walking and biking to school has dropped from around 41% in 1969 to just 13% in 2001. So initiatives like Safe Routes to School encourage physical activity through things like changes to the built environment. You need to change the built environment really to be amenable to active transportation. And just one other note here on the key findings, the absence of evidence is not evidence of absence. Just because you don't see something that you have been working on or that you might have read other aspects of the built environment are associated with increased physical activity, they may not have been present in the reviews. So we were limited to what was present in the reviews that had been published. And I have a slide here next of an example of a built environment that does not encourage physical activity. So you can see here it's a very busy road, discourages walking and biking. There's no crosswalk. You can see the pedestrian right in the middle and the upper middle of the screen. And on the left, you can see there's a sidewalk, but it kind of ends after a little bit, and then there's no clear path, or there's a grassed area, but then there's a bush in the middle of where a pedestrian might walk, and so they might even have to step almost into the road to walk around that. And this would also be very dangerous for cyclists. The cars look to be moving pretty fast, and there's really little to no shoulder. Now in contrast, the next slide has a series of images that the research suggests encourages physical activity. So across the top from left to right, we see parks and recreation centers which provide both avenues for youth to be physically active and also destinations. See complete streets, public transportation. You see there's a barrier between the traffic and then people potentially on the sidewalk. There's vegetation, which is also associated with increased activity, traffic calming, safety aspects like traffic signals, traffic calming, like roundabouts and speed bumps. And then down the bottom you can see mixed-use zoning. So there are apartments and shops all in the same area, so it's easy for people to walk to destinations. And then more bike infrastructure in the lower right. Now, there are a number of research needs that we found, because this really is very much an emerging area in public health research. And so the impact of the built environment and physical activity is a relatively new area. In the Midcourse Report, we highlight a number of the needs, and they're listed here. One thing I do want to highlight is that research in this area is really challenging. Now, ideally, in a perfect world, researchers would be able to conduct randomized clinical trials where we'd build a number of new neighborhoods and then randomly assign people to live in those different neighborhoods and then follow them over time to see how active they are. But of course, that's in the real world, that's not going to happen. So we need to utilize different types of research designs and do different types of studies. But specifically, we need more studies that have longer-term follow-up, that take advantage of natural experiments. And by that I mean changes to the environment that are happening anyway, that are under the control of policymakers. So we need to evaluate what happens before and after those changes. And then we also critically need more studies that look at the effect of different subpopulations by race, ethnicity, by disability status, socioeconomic status, and so on. And from a state health department perspective, I believe you can be very helpful to help build the evidence here in a couple of ways. One, potentially consider partnering with researchers in your area to see if you can evaluate activity changes before and after some change to the built environment. Or to consider setting aside funds specifically for evaluation to conduct that evaluation research. So here you can see an infographic that was developed for the Physical Activity Guidelines report. I encourage you to go to the website listed here, health.gov, PA Guidelines, and download the report, share it with folks. Feel free to download this infographic as well, which really highlights the importance of each of the 5 settings to help youth get 60 minutes or more a day of physical activity. And with that, thank you everyone for your time. My contact information is here, so please feel free to contact me. I'm also very happy to answer questions after the other presentations. Thanks so much.
Great. Thank you, Dr. McKinnon. And as you can see on your screen, we have a polling question up. Which stakeholders whose primary mission is not physical activity promotion play an important role in promoting physical activity in the built environment? Please go ahead and submit your answers now while I introduce our next speakers. Our next speakers are Janet Haru from New Jersey Department of Public Health and Elise Bremer-Nye from the New Jersey Department of Transportation. Ms. Haru works at the New Jersey Department of Public Health to advance policy and environmental strategies to prevent chronic disease, especially physical activity promotion. She used to chair the Town of Princeton's Bike Ped Advisory Committee and now serves on the Health Board. She began her career as a Peace Corps volunteer in Afghanistan. Ms. Bremer-Nye is a licensed professional planner with the New Jersey Department of Transportation's Office of Bicycle and Pedestrian Programs, where she serves as a Safe Routes to School program coordinator. She has worked on bicycle and pedestrian issues for the last 15 years and happily walks with her daughter to school every day. Okay, the poll is now closed, and as you can see, most everyone chose the correct answer, which is all of the above. All of those stakeholders play a role in the promoting physical activity within the built environment. And now I will turn it over to the team from New Jersey.
All right, great. Well, we're glad to be here, finally. This is Elise Bremer-Nye with the New Jersey Department of Transportation. I'm going to jump right in because we have a lot going on and we don't want to be short on time. Today, New Jersey is a state with an award-winning State Complete Streets policy, 5 county policies, and 57 municipal policies to ensure that all roadway projects address the needs of people on foot, on bike, or in a wheelchair. We have funded Safe Routes to School projects in almost 100 towns in all 21 counties, and have reached over 300 schools with our statewide program to give more children the opportunity to get valuable physical activity on the trip to and from school. Several of our state agencies are now partnering with each other to improve the health of our citizens. We were not always such an enlightened state, so let us tell you the story of how we got here, and how you can too.
Hi, this is Janet from the Department of Health. Can everybody hear me? Since this is about how the Health Department in New Jersey has partnered with the Transportation Department to promote routine daily physical activity, please let me introduce the Health Department side of the effort. I have operated from the Office of Nutrition and Fitness at the Health Department, which was created in 2007 to address the obesity epidemic. We have been supported by one of the CDC Nutrition, Physical Activity, and Obesity grants, which for New Jersey was $4.1 million over 5 years to build an obesity prevention infrastructure, to increase access to healthy food, and germane to this conversation, increase opportunities to be routinely and daily physically active. Through that NPAO grant, the Health Department created Shaping NJ, which is a public-private partnership of over 225 partners, including large state agencies, the New Jersey Department of Transportation being one, businesses, hospitals, not-for-profits, the League of Municipalities, which is the association of our 566 municipalities across the state, and advocacy groups such as the Tri-State Transportation Campaign. Next. I was the physical activity specialist for the partnership, and from day one found the 2008 Physical Activity Guidelines for Americans to be an essential source for my work with health and non-health agencies as well as the public. It turns out that Elise and her colleagues in the bike ped field felt the same. Many authorities had described the amounts and types of physical activities that Americans need to maintain lifelong health, but the guidelines put it all together in such a user-friendly way. Over the years, we have used information from the report in presentations to engineers, teachers, school boards, planning boards, mayors, and of course our colleagues at our respective departments. We cite it in our reports, and we've made the report available on our websites and newsletters.
New Jersey Department of Transportation's efforts to promote biking and walking actually predate the Department of Health obesity prevention push. But it wasn't all that long ago that the New Jersey DOT was the New Jersey Highway Department, building many roads without sidewalks or bicycle lanes. We were primarily concerned with moving more cars along more roadways more quickly. And though safety was always a priority, people who traveled without cars, whether by choice or by circumstance, often felt that their needs were not being met, and many times they were not. Things began to change in 1991 when federal legislation instituted the position of a statewide bicycle and pedestrian coordinator at each state DOT to work with an advisory group representing the interests of people who travel on foot or on bike. Every state has one. Through the 1990s, NJDOT had only one man leading this effort, but within 10 years, the Office of Bicycle and Pedestrian Programs had grown to a staff of 5 with consultants and university support. The New Jersey Bike Advisory Council met throughout the 90s, made up mostly of transportation planners and engineers and local bike clubs. A statewide pedestrian task force was convened in 1999. At about the same time, the New Jersey Bicycle and Pedestrian Resource Center was established using federal funds at the Voorhees Transportation Center at Rutgers University, which is where Janet and I are sitting today. This center provided administrative support to both the Bike Council and the PED Task Force and combined them in 2004. Guess who DOT invited to join the group? Department of Health. NJDOT also receives federal support for Safe Routes to School. The main goal of this program is to enable and encourage children to walk and bike to school safely on a regular basis. DOT gives federal grants to towns to build sidewalks and bike paths and runs a statewide program to teach children how to walk and bike safely. Guess who we invited to help advise the program? Yes, Department of Health. And guess what information we use in every presentation to stress how important it is that children get some activity on the way to and from school? The Physical Activity Guidelines. And now we come to the real partnership, Complete Streets. In October 2009, the Township of Montclair passed the first CS policy in New Jersey. NJDOT passed its policy 2 months later in December 2009, and ever since has been rated the #1 statewide policy in the U.S. Because most of the roads in New Jersey are under county or local jurisdiction, we knew we had to get the word out about what Complete Streets were, how to pass and implement Complete Streets policies, and why it is so important to do so. We held a Complete Streets Summit in October 2010 and ran CS workshops across the state in 2011. Department of Health was among the groups who helped us get the message out.
Back to Janet. At the same time that the DOT was navigating the Complete Streets policy through the department, it also signed on as a partner in Shaping NJ. That year was 2009. Our focus is policy and environmental change. Increasing physical activity is one of Shaping NJ's goals. It's one of the behaviors associated with obesity reduction. What are two of the easiest ways for people to get physical activity? Walking and biking. Where do they do this? Ideally on complete streets with sidewalks and shoulders and crosswalks. How do you get these complete streets in New Jersey? You pass and implement Complete Streets policies. In addition to the excellent Department of Transportation and Voorhees websites, Shaping NJ has fact sheets on Complete Streets on our website, and our entire network of partners with expertise to help communities do it.
In New Jersey, you can also find out about Complete Streets via Sustainable Jersey, which is a certification program for municipalities that want to go green, save money, and sustain their quality of life. It is completely voluntary, yet more than half of the 567 towns in New Jersey are registered in the program, and 114 are certified. Basically, it's a way for towns to earn points to be able to say, I'm greener than you are. And it's been very successful. There are 16 categories of actions, such as land use and transportation, and health and wellness. DOT and DOH sit on these committees, so two of the actions that towns can undertake to earn points are implementing a Safe Routes to School program and passing a Complete Streets policy.
Back to Janet. So, this is all very exciting for me to tell folks. So now we have state agencies like transportation, health, education, environmental protection, and private groups like Sustainable Jersey, all working together to accomplish mutually supporting goals. We make the connections anywhere and everywhere it makes sense. For example, DOT awards extra points to Safe Routes grant applications from communities with school wellness policies, and DOH has arranged for consultants from DOT to help their Shaping NJ community grantees with Complete Streets policies or Safe Routes to School programs. For example, Trenton, a city who already has a Complete Streets policy thanks to the efforts of many local partners, received one of our Shaping NJ community grants. Through that grant, the Trenton team recently brought in state and regional transportation folks who worked with several local faith-based communities around 3 elementary schools to conduct walkability assessments for Safe Routes to School. This was truly a remarkable local partnership and an interesting way to engage faith-based congregations in policy and environmental change. So I am excited to say that Complete Streets is becoming a part of New Jersey Department of Health's DNA. Parts of the department beyond the Office of Nutrition and Fitness are supporting NJDOT's efforts to promote Complete Streets. Our Office of Local Public Health gave almost $70,000 to Voorhees at Rutgers to help implement local Complete Streets programs in all of New Jersey counties. Our Department of Health funded regional chronic disease coalitions are now required to implement either a shared use agreement or a Complete Streets policy to get their funding, even though I have to admit some of the folks out in those regional coalitions may not yet know what Complete Streets are.
And right now we are working on something really exciting, at least it is to a transportation geek like me, health and transportation policy. Together North Jersey has received a Sustainable Communities Grant from HUD, USDOT, and EPA. As a part of that project, they were able to bring in professionals from other states to speak to our network of partners. Massachusetts talked to us about using health impact assessments in transportation projects. And Nashville's Metropolitan Planning Organization told us how they use health statistics to determine the funding for transportation projects in their region. We are working to make that happen in New Jersey. And in fact, the Voorhees Transportation Center recently convened the second roundtable on health and transportation policy. And of course, the Department of Health is at the table. Now, why is my office so excited about physical activity guidelines? Well, they've given us a lot more credibility. In the past, when we spoke to an engineer about pedestrians getting hit when they walked along or tried to cross a state highway, the first suggestion an engineer would have was, put up a fence. It was all about safety. In their minds, it was safer if people just did not walk out there. But now the evidence is everywhere. Physical activity is critical to overall health, and people need to be able to walk and bike. A DOT engineer's reaction today is, how do we design the project to meet everyone's needs?
I think you all understand why Shaping NJ and the Department of Health are so excited about Complete Streets and safe routes to schools. To sum it all up, we at the Health Department know we depend on our non-health partners to create the conditions that keep people healthy. New Jersey is fortunate to have had such a progressive Department of Transportation whose leadership has understood the importance of physical activity to our health and has supported the drive for health in all policies. And Elise and I both want to thank our many, many, many partners that we may not have mentioned in these slides, but we're so grateful for all of our New Jersey partners and all the New Jersey communities for being willing to come out of your silos and work with us. Thank you so much.
Great. Thank you, Janet and Elise, for that wonderful presentation.
You're welcome.
And as you can see on your screen, we have another polling question up. Which of the mid-course report's recommended interventions to increase physical activity in the built environment are you most likely to implement? Please go ahead and submit your answers while I introduce our last speaker. Our final speaker is Dr. Meg Ann Tracy. Dr. Tracy is a developmental psychologist and research associate professor at the University of Montana. She works with the Montana Department of Public Health and Human Services on its Coordinated Chronic Disease Program and has directed its Montana Disability and Health Program for the past 11 years. She is interested in lifespan development and resilience, particularly in the context of disability. Okay, the poll is now closed, and as you can see, most people plan to improve their walking and biking infrastructure. And now I will turn it over to Dr. Tracy.
Thanks, Kristen, and thank you for the opportunity to talk about our work here in Montana. I feel really privileged to be following the prior two presentations, and I just want to comment that as we're bringing Department of Transportation and Public Health partners together, this next presentation I hope provides some examples of how we can bring your disability community partners into that coalition as well. So I work at the University of Montana, but I'm officially on detail to the Department of Public Health and Human Services to direct the Disability and Health Program in the state. I don't have a lot of time to talk about all the wonderful inputs that really fuel our program and the context in which we work, but just thinking about the built environment and changes to the built environment in our communities, the work of the independent living community that started, for example, in 1988 with breaking down the curbs to create some of the first curb cuts in Los Angeles really helps to set in context the strength of the disability community in partnering on improvements to the built environment. We work very much within the social model of disability. And for more information about that model and how impairment and environment interact to create disability, I refer everybody to the World Health Organization's International Classification on Function, Disability, and Health. I provided a web link. I also want everybody to be thinking about the legal context in which we work and to protect and promote the civil rights of persons with disability. And the Department of Justice is certainly a resource for folks to rely on for technical assistance on the Americans with Disabilities Act. The Office for Civil Rights informs us about the implications of the Rehabilitation Act, Sections 504 and 508 specifically for the use of federal funds to promote the rights of persons with disabilities. And finally, the UN Convention on the Rights of Persons with Disabilities is a wonderful resource for promoting the rights of persons with disabilities worldwide. I want to also urge everybody, instead of spending time talking about disability as a health disparities population for physical activity, obesity, and related chronic disease, I really want to encourage everybody to familiarize themselves with the new resource from the Centers for Disease Control and Prevention, the Disability and Health Data System. That is an interactive system from which you can create local, state, data descriptions on a variety of indicators related to the physical activity guidelines. And or you can contact your BRFIS coordinator to start to compile some of the data to provide the rationale for some of the work that I'm talking about here in Montana. And finally, I want to highlight some of the calls to action, some of the reports, and some of the strategic plans that really support physical activity of persons with disabilities. So on the next slide, I listed Healthy People 2020 and provided a link to the focus area on disability and health. That includes the objectives related to disability and health, as well as a variety of resources for action on those objectives. I've also included a link to the U.S. Surgeon General's call to action to improve the health and wellness of persons with disabilities, a link to the strategic plan of the National Center on Birth Defects, Developmental Disabilities, and there are specific objectives related to obesity reduction in populations with disabilities. And I really want to highlight the U.S. Health and Human Services National Partnership for Action to End Health Disparities. And there's really specific activities that we can be doing to reduce disparities experienced by populations with disabilities. And finally, brand new and very exciting in terms of some of the resources being organized by a partner with a lot of capacity. UNICEF this year chose to focus their annual State of the World Children's Report on children with disabilities. And there are a variety of resources from staff training modules for building capacity of public health staff to work more inclusively with populations with disabilities to data on the health and wellness of children with disabilities. So those are just some of the context and inputs that partners in Montana are using in the Disability and Health Program. Sorry. So specifically, the Montana Disability and Health Program is a partnership between the Montana Department of Public Health and Human Services and the University of Montana Rural Institute, which is the Montana Center for Excellence in Disabilities Education, Research, and Services. The Americans with the Developmental Disabilities Act funds one of these programs, at least one of these programs in every state. And if you're interested in finding who your local partner would be, I provided a link to our national professional organization, AUCD, and you can look that up. Other partners that we work with in Montana are our disability community partners. Those are the Montana Centers for Independent Living, as well as other disability service providers. Some of the national resource centers I want you to be aware of are the National Center on Health, Physical Activity, and Disability. And also, just for your information, there are 18 states currently funded by the CDC to promote the health and wellness of persons with disabilities, and I provided a link to those currently funded states. So we've organized in Montana with the Disability and Health Program to integrate disability and public health agenda at 3 levels. At the highest level, we create a focal point for administrators from public health, your traditional public health divisions, and disability service provider divisions to work on promoting the health of people with disabilities through policy and data improvement. That's our core management team. And then we have organized a statewide community planning group. And on that group sits representatives from the State Health Department and also from disability community partners, including self-advocates and representatives from disability service providers. And then that planning group envisioned another network called the Montana Disability Advisors and created a set of guidelines for involving people with disabilities as members of advisory groups, specifically those informing public health planning processes. So in Montana, we work primarily to integrate disability issues within our chronic disease state programs. We have a variety of programs within our Chronic Disease and Health Promotion Bureau, including arthritis, asthma control, cancer control, cardiovascular health, diabetes prevention and control, disability and health, emergency medical services and trauma services, injury prevention, nutrition and physical activity, and tobacco use prevention. And in all the programs I provided an asterisk we have a disability advisor who has been recruited from the disability community and has been trained to serve on those boards and to really participate in the strategic planning processes of those public health standing committees. Those efforts often lead to accessibility ambassadors projects. That is, all of these strategic plans are trying to influence settings where people live, work, and play. The accessibility ambassadors projects help us to promote accessibility to members within those sectors. And importantly, they bring back information to clarify the needs for people with disabilities to promote health within those settings as well. For accessibility ambassadors, it's basically envisioned as a social marketing strategy. And in a rural state, it's really important that we take this approach as opposed to a legal approach to promoting accessibility. Basically, we target community sectors with health resources. And I'll talk about some of the settings that we've worked in a moment. We work to increase the awareness of accessibility and barriers and facilitators affecting people with disabilities, and provide action plans for improving accessibility in those settings. We also work to promote resources within those sectors on accessible inclusive environmental design, accessible and inclusive program implementation, and disability cultural sensitivity training. So this next slide just talks about what sandboxes are we playing in with the Accessibility Ambassadors projects. And this photo is from the Public Health Image Library at the CDC, and it shows a man using a wheelchair and pulled up to a sandbox that is universally designed to allow him to play at table level with 2 children who are seated in the sandbox. And they really are creating a built environment. So this is a text description of the previous slide for people who might access this PowerPoint later by a screen reader. So here are some of the built environment initiatives, some of the sandboxes that we've played in with the ambassador projects. The healthcare setting, where we're promoting accessible exam rooms, wheelchair scales, and adjustable tables, for example. We're working with the schools through the Safe Routes programs, really promoting safe and accessible routes to schools. We've worked on recreation areas and demonstration projects in Three Forks, Montana and Missoula on an accessible playground and accessible trails project. We've worked in 8 Montana communities to assess and promote accessible physical activity options within fitness centers. And we've also started to do capacity building with health enhancement educators and fitness professionals using the American College of Sports Medicine Certified Inclusive Fitness Trainer certification process and adaptive PE continuing education opportunities. And importantly, I'm not going to say much more about that in the rest of the presentation, but those two professionals both have a role in organizing the built environment to promote physical activity to people with disabilities, and the training that I've highlighted here really emphasizes capacity of those two professionals to do that work. And then finally, we've been working in the community, both with Complete Streets models, recruiting local disability advisors to be involved with local coalitions working in Complete Streets coalitions, as well as with accessible housing and primarily promoting visitability, which is best explained by concrete change. And I provided a link on visitability. And essentially that's basic access in every new home built for the open market. And there are 3 essential features for providing access to a home. The community health centers and rural health clinics in Montana are the specific setting in which we've done our health care work. And to relate back to the physical activity guidelines, those are for all Americans, and there are 2 recommendations for involving people with disabilities. One is that a person with a disability speaks with their health care provider about a fitness plan, and the second is to work with a fitness professional who is trained to develop a physical activity plan. Well, what we've noted in our work, looking at about 2/3 of the community health centers in Montana, and 3/4 of the community health centers and 2/3 of the rural health clinics in Montana, is that there are 0 exam rooms statewide that provide built environment facilitators that meet all the accessibility criteria. So in terms of getting an equitable exam to plan for a fitness program, that's one of the issues that we really are working on with our partners. And one of the outcomes of our efforts is that the 3 community health centers that were funded through HRSA for capital improvement grants included all of the barriers identified in our on-site assessments in their grants, and we'll be removing those barriers. The other setting that I want to talk about is safe routes to schools. And we really looked at some of the walkability checklists, and our community partners wanted to develop something that was more specific to describing the needs of students with disabilities. And so we developed the SARAC, the Safe and Accessible Routes evaluation criteria, and worked with our ambassador to do on-site assessments of 51 elementary schools statewide. And we focused primarily on the priority area 1, which is the block surrounding the school. And if you cross the street, that's priority area 2. And not one school had priority routes that met all of the accessibility standards, and approximately 1/4 of crossing surface, sidewalk surface, and alley criteria. And the majority of driveways for priority area 1 met all accessibility standards. And when we went to priority area 2, generally we saw more access barriers than in priority area 1, with the exception of driveways that tended to have fewer barriers than priority area 1. Here, the outcome is that we're really hoping to provide data that influences the funding of the Safe Routes to Schools infrastructure grants and the community planning that happens through activities like the Missoula Active Transportation Plan. The final setting I just wanted to touch on is an older project, and really kicked off our Accessibility Ambassadors project, where we worked with the Nutrition and Physical Activity Program in the state to identify 3 likely fitness centers that could provide access to physical activity for people with disabilities. And we did that in 8 Montana communities. And we really worked hard to identify what those physical activity options would be and promote them within the disability community. But it's important to note that again, disability resides as much in the environment as in the person, so that when we think about why aren't people as physically active when they have a disability, it is in large part due to the opportunities in the built environment. So in our work in the communities, we saw that 17% had 25 to 49 access issues in their fitness center, 25% had 50 to 74 access issues, 42% had 75 to 99 access issues, and 16.7 had 100 to 125 access issues. These are all issues that amount to hassles for a person with a disability, and cumulatively can really discourage people from meeting the physical activity guidelines. Some of the outcomes have been that we've activated the fitness center sector in Montana, and we've recruited Montana Inclusive Fitness Champions who are working to remove those barriers, and we've also been able to integrate really specific language into our state nutrition and physical activity plan on accessibility to assure the outcomes of that planning process are going to achieve health equity for people with disabilities. And I'll just leave you with a sign that's used in Missoula, Montana to mark routes to school to really illustrate that all this is reflected in the diversity of the population, and that when we involve people from all walks of life, that we achieve really equitable outcomes. So that's it, and I'll just put in the chat box my email address.
Great. Thank you, Dr. Tracy, for that wonderful presentation. We will now move into our Q&A for the presentation. So if you have any questions for any of the speakers, feel free to use the chat box located on your screen now. We have had a few questions come in throughout the webinar so far, and I know that they've been answered, but I just wanted to provide some context by reading the questions and maybe have our speakers talk more about the answers they provided in the chat box. So the first one was for our New Jersey team, and if you could just talk more about the best resources for walkability and bikeability assessments or other similar tools.
Sure. Can you hear me?
Yep, we can.
Okay, great. There's just a million of them online, so it's really not, we've never tried to reinvent the wheel. There were so many that were easy to find, whether it's the Pedestrian and Bicycle Information Center or the Association for Bicycle and Pedestrian Professionals, or even the National Safe Routes to School Resource Center. Everybody has links to walkability and bikeability assessments, and they are very easy to use. Most of them are basically the same, so you don't have to reinvent the wheel. You can just Google it and go right to several resources that will take you there, and you can just use them offline.
Great. Thank you. The next question is for Dr. Tracy. What disability policy agenda complements the physical activity guideline agenda for improving the built environment?
Well, I'm here today at a meeting about Community First Choice Option, which is a Medicaid option that states have to provide personal assistance services to people with disabilities. And I would say that the extent to which the community is accessible, that there are facilitators in the community that meet the needs of the diversity of the population, really helps to reduce the personal assistance needs that people have. And so in Montana, we've got a program on disability and health because the Supreme Court Justice, the Supreme Court decided that states must provide services to people in the least restrictive environment. And every organization has to think about how they're going to promote that. And public health really saw a role for doing that, in particular in getting involved in the built environment and thinking about it from a disability perspective. So that when we're looking at sidewalks, we're really thinking about it from the perspective of somebody who has a mobility impairment or somebody who has a sensory issue, and that some of the elements of accessibility for those populations are pretty specific, including things like cross slope and truncated domes and the crowning of roads. All of those things really do affect a person's ability to be independent in their environment and to be physically active.
Great, thank you. The next question is, what are some techniques the local contractors can use to improve the physical activity environment without appearing to be lobbying? I don't know if maybe New Jersey wants to take a shot at that, and maybe Robin with your background in this as well.
Well, maybe New Jersey might be better placed, and I can just jump in if there's anything to add.
This is Janet from Jersey, and I'm not an expert on what lobbying is, but I have worked not only for a state agency but also for a foundation in the past, who also have severe strictures on lobbying. I would say that if a local contractor is implementing a bike lane, I'm not sure what, some kind of a pedestrian-friendly intervention. I guess this person means physical. Local contractors can use to improve the physical environment without appearing to be lobbying. First of all, you're not saying anything. And I mean, unless there's some legislation before either the state or federal government, I don't think it's lobbying. These are, I guess I'm not quite, if Ms. Haydu could clarify her question, I can't see how that's lobbying if you're building a sidewalk or something like that.
Right.
I really wouldn't. That would not be my first concern. You might get, there might be folks who object to you spending public money in that fashion. There are always different points of view, but per se, I don't think that's defined as lobbying.
Okay, thank you so much for that. The next question that came in is for Montana, and have your accessibility measures primarily pertained to physical accessibility?
For every sector, we work with our partners to describe what's missing. For the healthcare setting and for the fitness centers, those tools measure programmatic access as well as staff training. So the AIM-Free really looks at fitness center policies as well as staff training. And the healthcare assessments that we've developed look at those as well. And we've primarily adopted the Massachusetts Facility Assessment Tool as our core assessment tool for healthcare facilities. And then we have a supplemental tool that also looks at staff training and communication barriers. So whether or not materials are provided in accessible formats, for example.
Okay, thank you. The next question, that maybe New Jersey and possibly Montana can take a shot at this, but was any evaluation completed after the environmental changes were made to assess physical activity among local residents? And if so, what kind?
Can we do? DOH hasn't done specific, big scale environmental changes. We track amounts of physical activity through our behavioral risk factor surveillance system, but no before and after changes. For example, in a community that has a complete streets resolution, it's really too early to tell, I think, to evaluate this. It absolutely must be done. And we have a little clarity. Ms. Haydu clarified regarding lobbying. She meant going to a city council or planning department. Okay, good. So obviously public officials cannot lobby for certain policies to be adopted in a community. They can educate, and they can also allow, if local advocates are also interested in an issue, local advocates can speak. But you're correct that you can't. A public official can't go to a city council and lobby on behalf of legislation passing. That's true. And again, we have a lot of local groups. Sustainable Jersey has municipal teams in many of our towns. We have tri-state transportation campaigns. So we do have a fairly vibrant advocacy community for walking and biking in New Jersey. Some come out because they want to increase physical activity. Some come out because they want to reduce fatalities, pedestrian and bike fatalities. There are various motivations for wanting to implement bike and ped facilities.
Actually, Kristen, I could jump in here also. This is Robin, and just comment on, I'm at the National Institutes of Health, as mentioned, and we are providing funding for a large Complete Streets initiative, but that's in Salt Lake City in Utah, and a multi-million-dollar, multi-year study that's underway. We're putting out accelerometers on folks, and so there. And I'm sure that there are a few other studies that NIH is funding, and CDC potentially, and then other research going on. So maybe not New Jersey specifically, but certainly that research is being funded underway, and by partners like the Robert Wood Johnson Foundation.
Great, thank you. And at this time we're going to end the Q&A. And I just want to thank you all again for joining us today. And as I mentioned earlier, you will be immediately directed to an evaluation at the conclusion of today's webinar. Please fill this out as it provides us with useful information for our future project. It also has questions related to the work you are doing to increase physical activity in your state. I would like to thank the Office of Disease Prevention and Health Promotion for sponsoring this webinar. And I would also like to thank our speakers, Dr. Robin McKinnon, Janet Haro, Elise Bremer-Nye, and Dr. Meg Ann Tracy. A recording of today's webinar will be available on our website within the next few days. The web address is on your screen now. Please check our newsletters and website for more information regarding the final webinar and our Physical Activity Guidelines for Americans webinar series, which will be hosted later this summer. If you would like to subscribe to the ASTHO's Primary Care and Prevention Network newsletter, or if you have any follow-up questions, please contact me at kwan@astho.org. We hope that all of the listeners will use this webinar as a resource and will share the link with others once it is available. Thank you and enjoy the rest of your day.